name is Richard Barth. I'm a hand surgeon at Washington Orthopaedics and Sports Medicine. I've been in practice for 20 plus years here. I see patients down on K Street in Chevy Chase and here at our Sibley office in Northwest Washington. I operate at Sibley Hospital, mainly in the outpatient surgery center, as well as at the Bethesda Chevy Chase Surgery Center. Hand surgeons treat all of the conditions, the entire upper extremity. We treat problems with the arm, the elbow, the forearm, the wrist, and the hand. And we treat the gamut of conditions, including we treat arthritis, fractures, nerve injuries, tendon injuries, sprains and strains. We fix tendons, and we treat the soft tissue injuries of the hand. Our approach to hand surgery is to treat each patient individually and to really resolve their problem. Each patient has different needs and different expectations and different demands. A concert pianist is different than an elite athlete, is different than an attorney, and we have to treat each of these patients individually. So our goal is to come up with an accurate diagnosis, come up with a treatment plan that's specific for the patient, and then try to resolve their problem as minimally invasively as possibly. And the vast majority of people we treat, even though we're hand surgeons, we treat non-operatively with therapy, with splinting, with anti-inflammatories, and sometimes simple things like activity modification and just some education. And we believe that the patients need to participate in the decision in terms of treatment, and so we try to educate our patients. Well, there's a number of conditions that we now treat much less invasively than we used to. For example, carpal tunnel surgery, we used to treat with an open procedure. We made an open incision in the person's palm and even up into the forearm sometimes. And now we can treat it with a much smaller incision, and often we treat it endoscopically. And what this results in a much quicker recovery, and patients are much quicker to return to activities, whether it's work, sports, or whatever. So it's made a real big difference in terms of treating our patients. Another example would be at the elbow. There's a nerve called the ulnar nerve, which can be compressed at the elbow. And we used to make a big incision and move the nerve, and it was a long recovery. And now we treat it much less invasively. We make a small incision and just free up the nerve, and usually the recovery is very rapid, and there's really very little downtime. That's another example of a condition that we used to treat with a much bigger operation that we now treat with a much smaller operation. Another example of a newer technique or procedure that is much less invasive is when we treat Dupuytrens disease. Dupuytrens disease is a genetic condition where the normal tissue in your palm becomes thickened and can contract your fingers so that you really can't get your fingers straight and out of your palm. And so when I started in practice 20 years ago, the only way to treat it was either live with it or to have surgery. And the surgery works well, but it's a big recovery for patients. They're often out of commission for many weeks to months. It requires extensive therapy, and it really takes months and months before they're back doing everything. About 10 years ago, I started doing a new procedure called a needle aponeurotomy, which is an office procedure where we numb up the palm, and using this tiny needle, we cut the cord in the office under local, and then what we do is we can release the cord, and patients can go back to light use almost immediately and full use in 2 weeks, and there's generally no therapy requirements. So it really changed how we manage Dupuytrens. About 5 years ago, a new drug came out called collagenase, or Xiaflex, and this drug is a chemical way of doing the same thing as the needle aponeurotomy. What we do is we inject the medicine into the cord in the office, and then a couple of days later we have the patient come back, and we can actually rupture the cord under local anesthesia and straighten the patient's fingers out. So instead of requiring surgery with a lot of therapy and a big recovery, we now can treat these patients with an office procedure with very minimal downtime, and it's really revolutionized how we treat Dupuytren's disease. I used to do surgery 4 to 6 times a month on it, and now I probably do maybe 4 to 6 surgeries a year on Dupuytren's because we manage it mostly as an office-based procedure. One of the newer Orthopaedics that has really changed how we treat patients is the advent of some of the newer plates that are now available for treating wrist fractures. When I started in practice, we often had very limited options, and one of the things we did was we put what's called an external fixator on a wrist fracture when they were displaced, and it's kind of like an erector set. And patients did reasonably well, but they didn't really like it very much, and we didn't have a lot of options in terms of how to adjust things. And about 10 to 12 years ago, new plates became available, which now allows us to fix these fractures much more rigidly and with good stability, and get patients rehabbed a lot quicker and a lot faster. As a byproduct of this, we can also treat patients conservatively longer, because I can now fix their wrist fractures at 3 or 4 weeks if they shift, and still fix them with a plate, where 20 years ago it was very difficult to treat them with an external fixator once they collapsed. So this has allowed us to actually treat patients more conservatively, because we have a better option down the road to manage them if the fracture does shift. When you come to see us here at Washington Orthopaedics and Sports Medicine, the first thing we'll do is take a complete and careful history. And particularly with hand problems, it's very, very important to find out what the person does for a living, what activities they do, what their hobbies are, because treating a pianist is different than treating somebody who plays sports. The next thing we do is we would do a complete physical examination that would involve the affected part, and we would do some special tests to figure out what's wrong with you. A lot of times with the history and the physical examination, we pretty much know what's going on. Sometimes we'll also take some x-rays. Many of the problems that we treat require physical therapy or occupational or hand therapy, and we have skilled therapists that we work closely with and communicate with, and we sometimes will send our patients for some therapy, sometimes we'll send them for some special imaging studies, but that's what you can expect when you would come to see us. We have our own physical and occupational therapists here. We have our own x-ray here, so everything can be done fairly expeditiously. At Washington Orthopaedics and Sports Medicine, myself and my partner David Moss are both hand and wrist elbow specialists. In fact, in our practice, every one of us is a specialist in a specific area, so that we're all we're not generalists, we're all specialists. So if there's something that you have that I can't take care of, I can have one of my partners take care of it, who is an expert on that problem.